The following podcast is part of a certified educational activity titled The BCMA Playbook in Multiple Myeloma, Mastering Sequential Strategies with Bispecific Antibodies and CAR-T Therapy. Access the entire activity and complete the post-test at peerview.com/HAZ860. Downloadable slides and practice aids are also available.
Hello, my name is Dr. Caitlin Costello. I'm from the University of California, San Diego. I'm pleased to be joined by my colleague, Dr. Shaji Kumar from the Mayo Clinic. Welcome to the BCMA Playbook in Multiple Myeloma, Mastering Sequential Strategies with Bispecific Antibodies and CAR-T cell therapy. Today, we're going to explore the current status of immunotherapy in the form of CAR-T and bispecific antibodies in multiple myeloma, with a specific focus on BCMA-directed treatments. We'll also discuss promising new directions and long-term evidence with these modalities and what that means for your practice. We will also provide insights on how we think about selecting and sequencing these strategies while also reviewing some key take-home principles for safety management. And with that, let's begin. Just to start off with some objectives, some of the things we hope you'll learn today. Current guidelines recommend BCMA and non-BCMA immunotherapy for the treatment of multiple myeloma with both early and or later relapse. CAR-T shows long-term efficacy in multiple myeloma. Dual antigen targeting is promising and perhaps an emerging approach with bispecifics. There's an emerging consensus on immunotherapy sequencing in BCMA naive and exposed patients. And we'll touch on strategies such as early planning, referrals, supportive care, such as the use of tocilizumab, infection prophylaxis, and we'll talk about keys to facilitating the safe delivery of immunotherapy. Well, I think it's important to level set from the beginning to help us really understand why there is this need to target BCMA in relapsed myeloma. And what we know is that despite so many wonderful, effective treatments for the patients with relapsed myeloma, we unfortunately know that high attrition rates persist, and that patients who have been treated with our standard classes of drugs, and particularly those who are lenalidomide refractory or have received 1, 2, 3 or more prior lines of therapies, unfortunately have continued dismal outcomes. One of the wonderful parts of kind of regulatory progress that we've seen, however, is with both BCMA and non-BCMA targeted immunotherapies, with the development and subsequent approvals of CAR-T cells. These in 2021 and 2022 led to the approvals of ide-cel and cilta-cel for patients with late relapse after 4 or more prior lines of therapy, these both targeting BCMA. It was in 2022 and 23, however, where the new approvals were seen for both BCMA and GPRC5D targeting bispecific antibodies, with 3 bispecific antibodies currently approved. In 2024, the continued development of BCMA targeted CAR-T cell therapies led to their approval with patients with early relapse. And still many more to come with emerging BCMA targeting bispecifics and the kind of reappraisal of belantamab or belamaf, as we hope to see it soon back in the United States. Well, where do we stand today with CAR-T cell therapy? In our current guidelines, as shown by NCCN, we know that CAR-T cell therapies are recommended for early relapse in multiple myeloma. There are a handful of different options that are available for patients who've had 1 to 3 prior lines of therapy, what we refer to as early relapse. And that can be broken down based on patients and their refractoriness or their disease refractoriness to prior therapies. However, CAR-T cell therapy is approved and listed in the NCCN guideline based on CARTITUDE-4 and KarMMa-3 trials, showing that both cilta-cel and ide-cel can be reused in early lines of therapy. This is based on trials showing, including the CARTITUDE-4 study, which was comparing the use of cilta-cel to standard of care therapies and showed that cilta-cel was associated with an improved progression-free survival and overall survival when compared to standard therapies that could be used at the discretion of the investigator. And this was true across all patients, including patients with high-risk cytogenetics, where patients benefited from receiving cilta-cel over the standard of care. That was also seen with patients in terms of overall survival, that all patients, based on their cytogenetic risk, improved or had improved benefits from receiving cilta-cel relative to standard of care therapies. With that, it was launched on the heels of we know that CAR T-cell therapy is so very effective for our patients in later relapse. This was supported by the CARTITUDE-1 and KarMMa-2 studies that evaluated and led to the approval of these BCMA targeting CAR T-cell therapies for patients with late relapse, what we refer to as more than 3 prior lines of therapy. And each trial led to the approval of those patients to be able to receive it for 4 or more prior lines of therapies. Remember, however, though CAR T-cell therapies for late relapse are an important option, this is the same place where we can use bispecific antibodies just the same, such as elranatamab, talquetamab, and teclistamab. Some recent updates on the CARTITUDE-1 study that was, again, remember, evaluating patients with late relapse, and finally had some longer-term follow-up looking and remarkably showing that after close to 5 years of follow-up, a third of these patients, remember, very heavily pretreated, most of them triple-class refractory, were still in remission now more than 5 years following a single infusion of cilta-cel without any maintenance therapy thereafter. And approximately half of those patients were still alive now 5 years later. These are incredibly unprecedented results on a very relapsed and refractory population that suddenly has new hope with this new treatment. When in a particular subgroup of patients that were treated in CARTITUDE-1, when we're trying to understand just how well these patients were doing, there was a highlight of 12 particular patients that were seen and treated at one single center on CARTITUDE-1, and following up these patients showed that all 12, still in remission, were all also MRD negative and showed their imaging was also negative here, now 5 years later, suggestive of a possible cure for these patients. All very exciting. Now, we've talked a lot about the wonderful successes and the efficacy of these treatments. However, it's important not to lose sight of the major toxicities associated with CAR T-cell. We know that these can be broken down into both acute and later and longer-term toxicities. But let's focus first on some of the more acute toxicities that can be seen, and those include cytokine release syndrome and ICANS, or neurotoxicity. We know that this is seen with both of the BCMA-targeted CAR T-cells, with approximately 85 to 95% of patients developing CRS. Now, it's important to recognize that with different CAR T products, the timeline and the duration of onset of CRS can be different. And with ICANS, however, it's approximately 20% in both of these products. Now, because we are using lymphodepleting chemotherapy for both of these products, infections are very common, where we can see higher grade infections in 20 to 30% of these patients. And it is of utmost importance that we have a high awareness for that possibility of developing viral, bacterial, and sometimes even fungal infections that can happen early on in their CAR T course, or perhaps even later on just the same. It is important also to recognize that some of these patients may develop some delayed motor neurotoxicity that can include movement disorders, Bell's palsy as examples. So some of these take-home messages in terms of the delivery of CAR T-cell for myeloma is know who your local academic center is, or your CAR T-cellular therapy program. We really want to make sure that we, as your CAR T-cellular physicians, are able to offer these patients CAR T-cell therapy exactly when they need it. And it sometimes takes longer than any of us would like. So please make sure to make these referrals early when possible. Oftentimes, we like to see these patients at the time of their first relapse to see if that would be the right time for them to undergo CAR T-cell therapy. In preparation for CAR T-cell therapy, it's important to recognize that alkylator use as part of your treatment can really hinder our ability to use those T-cells. So prophylactic steroids, alkylator treatments are those that we'd prefer to be avoided. It's important to be familiar with CRS and ICANS, recognize the importance of tocilizumab and dexamethasone as of treatment, and as mentioned before, be familiar with the infection management and the importance of long-term follow-up for some of these more unusual but important side effects that can happen. Well, I hope that's been very helpful to understand the background and the current landscape of the treatment of multiple myeloma with BCMA targeting CAR T cells. But I think it's important for us to recognize there are other options out there, and immunotherapy now includes T cell engagers as a way to target both BCMA and non-BCMA targets. Maybe, Dr. Kumar, you can walk us through the latest evidence.
Thank you, Dr. Costello. That is a wonderful summary of all the amazing developments in the CAR T field. So beyond the CAR T, we have other strategies for T-cell redirection therapy, and that includes the bispecific antibodies. And we have 3 of them that are currently approved for treatment of relapsed refractory disease, 2 of them targeting BCMA and 1 of them targeting GPRC5D. So both elranatamab and teclistamab are currently approved for patients with relapsed disease who have had at least 4 prior therapies, including an anti-CD38 monoclonal antibody, a proteasome inhibitor, and an immunomodulatory drug. And in addition, we have talquetamab targeting the GPRC5D that is also approved in the same patient population. So, as was already mentioned, CAR T-cell therapy, in contrast to what we see with the bispecific antibodies, are currently approved for early lines of therapy, with cilta-cel approved as early as the first relapse and ide-cel from second relapse onwards. Now, the next wave of clinical trials that are looking at the use of these bispecific antibodies are looking at variety of different combinations. And these include combinations of the bispecific antibodies with standard of care agents, including the immunomodulatory drugs, as well as the proteasome inhibitors and also other commonly used standard of care therapies. But what has really been interesting has been the combination of bispecific antibodies amongst themselves. There was interesting data from the Redirect 1 study that was published earlier this year that looked at combining teclistamab and talquetamab in patients with relapsed refractory disease. And these are patients who have been exposed to all the common drug classes and have had median of 4 lines of therapy. And what was quite impressive was the overall response rate at the recommended phase 2 was almost 80% amongst the 94 patients with relapsed refractory disease who were enrolled on this study. And the median PFS was not reached for this cohort in the initial study that was done. What was equally or even more interesting was the fact that this combination seemed to have high rates of efficacy in patients with extramedullary disease. Now, while myeloma is predominantly a disease of the bone marrow, we can detect disease outside the bone marrow. And when it takes the form of soft tissue plasmacytomas that are non-contiguous with the bone disease, patients don't do very well with that manifestation. While it's relatively uncommon at the time of initial diagnosis, we increasingly see these manifestations in the later stages of the disease. And the current therapies that we have available for these patients, including the conventional agents, the bispecific antibodies used by itself, and CAR-Ts, don't give us the durability of response that we would like to see in this patient population. So based on the initial results from the Redirect 1 study, there was a separate trial that was done and recently presented at EHA that looked at a cohort of 90 patients with extramedullary disease that were enrolled in a single trial. And amongst these patients, the combination of teclistamab and talquetamab gave a response rate of about 80%, almost similar to what we had seen in patients without EMD. But more importantly, had a progression-free survival that was around 15 months for patients with extramedullary disease, which is something that we have not typically seen in the context of existing therapies. And the 1-year progression-free survival rate was about 60%. And this is very important when you think about the sequencing strategies, even in amongst patients who had prior anti-BCMA, CAR-T, or anti-FcRH5 bispecific antibodies, or even the belantamab. The response rate did not seem to change much compared to the patients who are naive to these T-cell redirection therapies. Now, the question is, do we really need to combine 2 bispecific antibodies, or can we generate trispecific antibodies where you are essentially administering a single drug but with antibodies that have specificity against 2 different antigens on the myeloma cell, but still enable the T cell to target and destroy the tumor cells? So we saw the data with the J&J 5322 at ASCO, where patients were enrolled on a phase 1 study, and these were patients with triple-class refractory disease. And what was really impressive from that study was that in patients, all-comer patients at the recommended phase 2 dose, we saw a response rate of almost 100% if patients were naive to a previous BCMA or GPRC5D targeted therapy. So these results are clearly remarkable and something that we have not typically seen outside the context of CAR T-cell therapy. And these responses were quite durable, with 95% of the patients at the recommended phase 2 dose, free from progression at 12 months from the start of therapy. So clearly a remarkable change compared to what we have seen with the other therapies. The question that remains on the top of our mind, clearly we can use it for patients with late line relapse, 4+ lines of therapy. Ongoing phase 3 trials are looking at the bispecific antibodies alone or in combination with immunomodulatory drugs and proteasome inhibitors in the early relapse, the 1 to 3 lines of therapy. But even more exciting is the possibility that we could actually engage these molecules in the upfront therapy. And there are trials, including the Magnetism 6, which is looking at a combination of elranatamab, a BCMA targeted bispecific antibody, with daratumumab and lenalidomide. Again, the activity seems to be considerable with a 97.3% response rate, and the safety profile is very consistent with what we have seen with these individual drugs. So I think the results were significant enough and encouraging enough that these trials are moving on to, again, the phase 3 portion of their investigation. So I think the potential for incorporation of these bispecific antibodies in the upfront setting will give us the option of using a limited duration therapy and potentially avoiding these steroid-related toxicities in the future. So we won't go into too much of detail with respect to the dosing strategies. There is the practice aid that you can consult for the full details of the TCE dosing. But just briefly, teclistamab has 2 step-up dose and then it's weekly. After 6 months, patient can go to a bi-weekly dosing. Elranatamab, again, 2 step-up dose, weekly dosing, and then after 6 months can go to a less frequent dosing. With talquetamab, you have the option of using either a weekly or bi-weekly dosing right from the beginning. And then, of course, you can go down to less frequent dosing as patients respond and the patients have been on therapy for about 6 months or so. So I think, we already talked about the toxicity profile, which is quite similar between CAR-Ts and bispecifics, except with the bispecifics, we certainly don't see the higher grades of cytokine release syndrome and ICANS as we might see with the CAR-T therapy. So the basic principles of the CRS management remains the same. I think it's careful monitoring of these patients. Grade 1 is mostly supportive care, considered tocilizumab. With grade 2, you might need more supportive care, including fluids, holding the dose, tocilizumab, and steroids. And obviously, with any higher grades, then we will have to discontinue the PCE therapy and watch them very closely, often in an intensive care unit setting. So one of the key challenges with all these therapies is the infection risk, and we have to be careful right from the beginning, including all the prevention strategies, including vaccination, baseline testing for any latent infections, and also prophylaxis based on the baseline characteristics as well as the therapies given. And we often use BJP and varicella zoster prophylaxis. Uniformly, we see, particularly with patients getting BCMA-targeted therapy, significant hypergammaglobulinemia. And there have been several retrospective studies that have shown now that routine monitoring and replacement of with IVIG decreases the risk of infections in these patients. So clearly, we have seen incredible progress in the field with T-cell redirection therapy, whether we use CAR T-cells or whether we use bispecific antibodies. And with the increasing number of choices that we have in this area, the biggest challenge right now is figuring out how best can we sequence these therapies. So I'll hand it back to Dr. Costello to take over the discussion.
Thank you, Dr. Kumar, for that really comprehensive evaluation of our bispecifics. What a wonderful problem we have, that we have so many great immunotherapy options now, whether that's CAR T-cell therapy or whether that is bispecific therapies. I think it's worth mentioning some of the strategies and logistics surrounding the path to CAR T-cell therapy. And for the sake of some semantics, make sure we clarify what holding therapy is, what bridging therapy is, and what lymphodepletion chemotherapy is, because we all need to be on the same page as part of, I like to say, this team sport. So holding therapy, let's call holding therapy the treatment that the patient is receiving that is biding our time until the patient perhaps gets to the CAR T-cell therapy so we can start the CAR T process. This is before apheresis. This is before the T cells have been removed. Our goal with that treatment is to control the disease without jeopardizing the CAR T cell collection. This isn't standardized. This can be very different based on every patient's prior therapies, comorbidities. But I think the most important thing I've mentioned previously is avoid those alkylators, bendamustines, chemotherapies, things that are going to target our T cells and make it challenging to collect them for future use as a CAR T cell. Now, that is different from bridging therapy, which is the treatment that is used after apheresis is complete. So, this is the patient who has gone through the evaluation for eligibility for CAR T cell. Now, the T cells have been removed via apheresis, and we're waiting for that manufacturing time. During that time, we can do whatever we need to, with a main goal of keeping the patient as strong as possible, continued reduction in the disease burden, and making sure we are kind of getting the patient in best as shape as possible to have the most successful outcome for CAR T. And as mentioned previously, the lymphodepletion chemotherapy is standardized. This is our standard fludarabine cyclophosphamide that is used prior to the T cells being infused. Shaji, anything to comment on here? Anything that you do that may help our listeners in terms of holding versus bridging therapy?
No, Caitlin, I think it's very important distinction that you brought up. Again, I think the key thing is, don't hurt the T cells before you collect them, before the apheresis. A couple of things I just wanted to highlight, especially with the emerging data with use of bispecific antibodies for bridging therapy. There is some data suggesting that a drug like talquetamab could be used for bridging in patients who are going to a BCMA targeted therapy. Now, something like that can be quite effective, and because often the challenge is that by the time they get to some of the therapies like CAR T, they have seen a lot of the drugs and they don't really left with too many drugs to control the disease. So in order to prevent the patient from progressing and not being able to get to the CAR T, something effective like a bispecific antibody that's targeted towards a different antigen than the CAR T can play a role.
Well, I think one of the things that has been highlighted today between both your presentation on bispecific antibodies and the discussion on CAR T cells is just this embarrassment of riches, let's say. These wonderful options that we have that are targeting BCMA or GPRC5D, these immunotherapeutic approaches leaves us in a position of sometimes not knowing which to do which first. And so there's been a real push to help us understand the best sequencing of these treatments. And there's been some consensus guidelines that have been put out that are helping us to try and understand what is the right sequence and try and think a little bit about some of these things we're talking about. When to apherese, what to avoid prior to apheresis. Maybe we can talk through that a little bit in terms of some of those pre-treatment considerations, such as what treatments to avoid, timeline. Do you want to take that, Shaji?
Sure, Caitlin. I think you touched upon some of this already. I think the fact that we want to try and avoid certain drugs, certainly the high dose alkylators and the bendamustine, is important because they do cause significant lymphopenia and lead to failure of to collect good quality, adequate numbers of T cells. I think the other key things, from a practical standpoint, is the washout that we need before the apheresis. Certainly, we use a variety of different therapies, particularly with respect to anything that can have an impact on the T cells. I think we want to give a good um, long washout if it is possible. Obviously, as we take patients to treatment late stages, that may not always be feasible. I think that's again one another reason why we want to think about it early rather than late. And again, I think we have kind of touched upon this already, the importance of trying to get the disease burden down before we actually get them to the actual CAR T therapy.
I do want to highlight the importance of effective bridging therapy to debulk the disease, but the importance of maintaining the patient in the process in terms of their clinical strength and not letting them get too strong of a bridging therapy that is going to compromise their performance status in preparation for CAR T cell therapy is one example. So it's important to use kind of the most effective therapy that you have available to cytoreduce, but that which can perhaps be a limited duration treatment with as low as toxicity as possible. Okay, so now then we've talked about BCMA targeted CAR T cells and bispecific antibodies, and have made some brief mention about antibody drug conjugates. And so some of the questions that lie is, which order? Which ones should we be doing first? And are there certain scenarios where we may choose one over another because of perhaps the biology of the disease or patient preference or comorbidities, or choosing one therapy one target over another target? Are there some considerations that you take into consideration here when you're choosing for your patient in terms of sequencing?
Definitely. I think, again, we have limited knowledge. I think we are all making decisions based on the limited experience we have with all these agents. But again, as you said, we have so many choices. We have the T cell engagers, we have the CAR T cells, we have the ADCs. Couple of observations from all the studies we have done or we have had in the field is that when CAR T comes after a T cell engager or an ADC, the high 90+% response rate that we see does drop down to the 50s and 60s. And we also see that the durability of response goes down. I mean, when you're thinking about a therapy like CAR T, which is a once and done, at least for the majority of the patients, we want to get the maximum benefit out of the therapy. And again, it's a very expensive therapy, and many patients may have one stab at it. So we want to use that modality in a scenario where the maximum benefit can be accrued. And I think from that perspective, I think if you're thinking about a T cell redirection therapy, I think CAR T should be the first choice or the first option to be looked at. So if the patient can go to a CAR T, want to go to a CAR T, then we should definitely consider CAR T first, and that has been our practice. And if they cannot go to a CAR T for whatever reason, whether it's logistics, comorbidities, patient preference, then definitely a bispecific antibody would be a reasonable next choice. Now, even if the patients have had a CAR T, then we can certainly use the T cell engagers after that. We do see some drop in the efficacy, but not the same magnitude as what we see in the context of CAR T cell therapy. One other thing you pointed out, which is very important, is switching targets. I mean, thankfully, not only do we have 3 different platforms, we also have 3 different targets, allowing us a variety of different permutations and combinations. So, there have been preclinical or translational studies clearly demonstrating emergence of mutations on these antigens that might make it less susceptible to binding through of CAR T receptor or the bispecific antibody. So I think switching around the target to a different one, if somebody's gotten a BCMA targeted therapy, switching to a GPRC5D makes most sense. Again, these things may be moot point if you're starting to use trispecifics in most patients, then the switching targets may not apply as much in the future.
Thank you. I think highlighting one more thing there about, rapidly progressing patients. We mentioned about different scenarios where it may make you choose one over the other. CAR T is certainly our preference to be able to do first whenever possible, but there are scenarios where the myeloma is just relapsing faster than we can keep control of, and certainly faster than it will take for us to organize the CAR T. And so while our preference is for CAR T first, there are scenarios where rapidly progressing myeloma needs rapid intervention, and a bispecific antibody kind of off the shelf is something that we can intervene on and start very quickly for some of these patients. So in light of all of what we've just discussed, perhaps it would be most helpful to review specific cases that we can help clarify some of our approaches. Do you want to start with a case, Shaji?
Absolutely. So let's talk about this 64-year-old gentleman with a standard risk myeloma who got a quadruplet induction consolidation followed by a stem cell transplant, achieving a very good partial response post-transplant. Now, 30 months, 2.5 years later, this patient is relapsing on lenalidomide maintenance. So the question that comes up, obviously with all the choices that we have, should we be thinking about a CAR T at this point in time? Obviously, based on everything we talked about, we certainly want to have that education that, think about CAR T early, even if you don't think it's something that you're going to be using right away. And then obviously the question is, what kind of therapy would you start on this patient in terms of the whole logistics of planning a CAR T if you were to go down that route? And are there other things that might make a difference in or influence a decision about using CAR T at this point in time? So maybe Caitlin, I'll start asking you as to what would your choice be here? Would you use a CAR T, or would you think about a conventional triplet therapy.
So the things that I'm going to take into consideration when helping to make this decision and recommendation to the patient first is younger person, standard risk disease, daratumumab exposed but not refractory, but yes, refractory to lenalidomide as the patient has been on maintenance. And finally, kind of biochemical relapse where it sounds like it is a slowly rising M spike. Good performance status. So if you put all those things together, technically, yes, this patient is a candidate for CAR T-cell therapy at the time of first relapse. Now, specifically, only cilta-cel, because remember, ide-cel is for 2 or more prior lines. So this patient, by the label as being lenalidomide refractory and at first relapse, is eligible for cilta-cel. This is the patient I want to talk to because I think this is not necessarily clear cut in this particular scenario. We want to talk about the pros and cons of proceeding with CAR T. This is a scenario where if a patient has slowly progressing disease, sometimes that's a wonderful problem because you don't necessarily need to intervene as much because you don't have as much disease to debulk prior to CAR T. So a little bit of art, this is the art of myeloma and a little bit of kind of that gestalt to understand, do I need to debulk as is based on the disease burden at the time of it. So holding therapy is a consideration. Again, making sure that we're not targeting any T cells that could be compromised. But I think we have options for this patient. And I think this is unknown exactly what to do here and why shared decision-making is important. Because a daratumumab exposed and still sensitive patient has a lot of good therapy still available. Remember, the CARTITUDE-4 study did not include comparison as a standard of care with a really great triplet like daratumumab, carfilzomib, dexamethasone, which could be a really great option for a patient like this. And so when I'm thinking about CAR T versus a standard of care option, remember CARTITUDE-4 did tell us that cilta-cel benefits all patients, standard risk, high risk. But I think it's important to discuss at this point the logistics, the safety with both acute and longer term toxicity, and really help with shared decision making. As mentioned, think about whether a cocktail such as carfilzomib dex or proceeding with cilta-cel would be an option. Now, I think the scenario that's worth kind of thinking a little bit about is that if this patient had high-risk disease, still a CAR T candidate, cilta-cel again, the patient had 2.5 years of remission post-transplant after achieving just a VGPR. This does not meet criteria kind of for the functional high-risk outcome, but I do worry that this patient had a little more brief response and remission than I would have hoped. And so if this patient had high-risk disease, it certainly would be something that would perhaps encourage me to recommend CAR T-cell for them sooner than not. Anything you would do differently, Shashi?
No, I completely agree. I think, we have not been uniformly using, and patients have not been uniformly wanting CAR T in that first relapse because, again, we have so many time-tested combinations that have high efficacy and durable responses. But I do share your concern that the 30 months with their approach that should ideally have a median PFS of 5 years, it does indicate towards a higher than average risk patient. So certainly something to be factored in that discussion and shared decision-making process.
So, Shaji, in our next case, we have an older patient, 77-year-old woman with standard risk, triple-class refractory multiple myeloma with some comorbidities. It's important to realize she lives in a rural location. Now, she's had 4 prior lines of therapy. She is what we would call kind of penta-refractory. She's been treated with all of our main classes and all of our drugs, plus a few. And she's in a position now where her disease is progressing, and it seems like it's picking up in the pace of progression every time she relapses. And now her performance status is not as strong, down to a 2. Now, when we look at all of her prior treatments, remember, here she is. She's BCMA naive. Is now the time to recommend CAR T? Can she wait for it? This is a scenario I was referring to earlier where sometimes we get a little nervous in terms of waiting. If someone has rapid relapse, for example, we need to intervene sooner. And we have to know that the patient, if they're going to be able to proceed with CAR T, is able to kind of have that process move along. Here, this patient lives in a rural location. We need to understand where their closest CAR T center is. Do they have the support as an older patient to be able to go through the CAR T? Sometimes the stars just don't align well enough to allow CAR T to happen, as good as an approach as we think it is. And so in this scenario, perhaps a patient who is BCMA naive, it would be a better approach to use a BCMA targeting T-cell engager, such as elranatamab or teclistamab. I suppose you could also consider GPRC5D targeting at this point, but because we have two different targets that we're thinking about eventually using now and in her future, I think practically an older woman where we have concerns with comorbidities, I do worry a little bit about talquetamab weight loss, some of the quality of life and the changes to the mouth and taste and things. So I think my approach to this patient would be a BCMA targeted T-cell engager. And I would encourage the kind of healthcare team to really work closely with the patient and their caregiver team to figure out the best way to administer this. There are some centers that are doing it as an outpatient. There are more centers who are doing it still as an inpatient, and recognizing the way that we can adequately and most safely support these patients as they're at risk for developing, CRS and lesser so, but possible neurotoxicity. And so taking into some of the considerations, the details of the clinical status and the social support and comorbidities, are all scenarios where it would help me and guide our healthcare team and the patient and their caregiver to think about the best and safest approach for step up and eventual treatment dosing. Anything you would do differently, Shaji?
I completely agree with the approach. I think the key thing here is, somebody with comorbidities, CAR-T, as good as it is, may not necessarily be the right choice for all these patients. But the good thing is we have choices. And I completely agree with you in terms of the sequencing, going with a BCMA targeted therapy first, and then going with a GPRC5D targeted. The good thing is we have other things in the offing too. We have obviously bispecific antibodies targeting FcRH5, a third antigen, and then also CAR-Ts that are targeting GPRC5D. So I think the options are continuing to improve, and there are CAR-Ts which are being developed with a lot less toxicity than what may even be seeing at this point in time, and could be a consideration even down the lane when you have something against a different target.
And just as you previously mentioned, someday this would be a great candidate for the trispecific as a BCMA and GPR naive patient. Well, I want to thank you, Shaji. I really think this has been such a wonderful and comprehensive discussion, and I really hope it's been helpful to our listeners to really kind of understand the best approaches to our immunotherapeutic approaches for the treatment of relapsed multiple myeloma. We reviewed the data on CAR T-cell therapy, both in the early and the late relapse, looking specifically at BCMA targeted therapy, and really excited to think about some of the long-term data that we finally heard with a good handful of patients 5 years after the fact enjoying some long-term survival. I think we then touched on bispecific antibodies and reviewed some of the different new consensus guidelines, kind of helping guide us a bit to say we have a handful of different bispecific antibodies that target two different targets, at least for now, some that are coming with new targets, and trispecific antibodies, and thought about different means of when we would think about a bispecific antibody of its best use versus CAR T-cell therapy versus antibody drug conjugates. So we have in a short time reviewed quite a bit of data, and I really hope it has been helpful to guide you in your clinic tomorrow when your patient with relapsed refractory multiple myeloma comes to see you looking for your advice. So I thank you very much. And to my esteemed colleague, Dr. Kumar, thank you.
Thank you. Thanks for walking us through all the data.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from Johnson & Johnson. To access all materials for this activity, visit peerview.com/HAZ860.